Hi, this is Hillary Reagan, and I want to present the High Obesity Program from the CDC, specifically targeting rural obesity for my policy paper. So, first I want to talk about the facts of the societal burden of obesity, and these are the figures that stood out the most and seem to have the most impact. 42.4% of the American population is considered obese. In the year 2000, 15% of deaths were attributed to obesity. Many comorbidities and sequelae, including diabetes, hypertension, stroke, coronary artery disease, kidney failure, and vascular injuries. Certainly the list is probably longer than that, but these are the main comorbidities, and these comorbidities and obesity, their prevention as well as their treatment, cost the United States about $148 billion annually. That figure also includes loss of productivity from the workforce. The obesity rates continue to climb despite our best efforts. Not only does the obesity rate continue to climb, but the cost of obesity continues to climb because healthcare costs continue to climb. So certainly it is imperative that we figure out how to stanch obesity as an epidemic. It seems like our best efforts haven't even created a plateau quite yet, insofar as our ability to prevent it. More specifically, I am interested in rural obesity. Overall, there are urban and rural health disparities that are well known and health outcomes. There have been lots of theories and speculation, as well as research into why rural areas face more health disparities and more burden. Some of those explanations have included access issues, educational attainment, income level, poverty, transportation issues, and so forth. Interestingly, rural living used to have a protective relationship against obesity, meaning that it had a negative relationship with obesity. And I am really interested in why that has now flipped, and that urban dwellers are actually less likely to be obese than their rural counterparts at a rate of 28.7% versus 34.2%. So the protective factor of rural living has now dissipated and actually flipped, and I'm really curious as to why, and I hope to address that in the paper. The greatest differences between rural and urban health disparities lie in the South and the Northeast. There are also differences in cultural and ethnic makeups. So in rural Georgia, Black rural populations have a much higher incidence of obesity than do their white counterparts. In some parts of the Northeast, it's white rural white rural populations that actually suffer the most from obesity. So there is a difference therein, insofar as who comprises that rural population. And certainly there are different needs and different targets we need to address with those populations to be effective. So the High Obesity Program was a really innovative program that was launched in 2014 by the CDC. It was funded by Congress in order for land-grant universities, i.e. the University of Georgia in the state of Georgia, to work with the U.S. Department of Agriculture's Cooperative Extension Services, or their 4-H offices. I believe in the state of Georgia there are 3 or 4 rural areas that they are targeting. Their targets are those areas where obesity rates are actually greater than 40%, which is an incredibly high number. So what does HOP do? First and foremost, they're mandated to perform a year-long community assessment. So that includes a needs assessment as well as networking with community leaders and community stakeholders insofar as what that specific community needs. They network with community leaders. Specifically, what HOP targets is increasing food accessibility, marketing on healthy eating, education on obesity, as well as family buying behaviors. So what do I think that HOP misses, and what is an incredible opportunity to improve a federally funded program that has an enormous outreach nationally? I believe that it ignores the psychosocial conditions of poor health outcomes and the protective quality of hope, which contributes to long-term thinking or long-term bias. It also misses systemic social inequities that contribute to obesity and complex public health issues. And it fails to target community resilience as well as community and social/human capital. So there's an enormous body of research that actually indicates that building community resilience works synergistically with programs that target individual choices, meaning that the HOP, the High Obesity Program right now, is targeting effectively individual and family choices and those behaviors. But if we can combine community resilience and social and human capital, then those will work well with those programs that target individual choices to create better behaviors for the community. Targeting community resilience, human capital, and social networks, I believe, could be a missing link in approaching complex public health concerns such as obesity. Interestingly, the Department of Homeland Services in 2003 created a task force on community preventative services that effectively indicated that we were missing an opportunity, missing a chance to really create effective policy changes for public health that factor in systemic inequities and systemic infrastructure failures that contribute to community health and population health. HIAP is an acronym for Health in All Policies. And this was actually a policy that its seeds started in the 1970s and slowly evolved throughout the later 20th century. In the early 2000s, the World Health Organization was an enormous advocate of it. And what HIAP is saying is that we have to put public health at the core of every public policy issue that we debate and that we implement and that we operationalize, meaning that public health should be at the core of infrastructure conversations, it should be at the core of agricultural conversations, it should be at the core of transportation and education. So it should have a global, basically the framework for public policy is framed or at its core is public health. So we've known about this for a long time. We've known that this is really important. So what I hope to do, or what I hope to propose for my paper, is effectively adding an additional target to the High Obesity Program. So instead of targeting just individual choices and family behaviors, I would like to create I would like to increase the social and human capital in those communities where obesity is an incredibly high percentage. So what that means is working with community and business leaders to create entrepreneurial and micro-enterprise opportunities for youth and adults, exploring job skills training programs, incorporating nutrition information, as well as obesity education and programs based on improving the lives of youth and or adults, utilizing existing relationships with community leaders, and expanding community assessments to include economic shortfalls and job opportunities or lack thereof. And lastly, partnering with economic development sectors. This slide speaks for itself, but I guess I will just go ahead and say it anyway. Decreasing obesity incidence and providing obesity prevention requires a multi-system approach that recognizes the complexity of obesity and the importance of the many psychosocial factors that influence our behavioral choices. So in summary, by expanding the High Obesity Program to factor in social and economic considerations and building human capital, I hope to expose the relationship between hope, community resilience, long-term thinking, and better public health outcomes. That means a multi-system approach that incorporates individual choices with recognition and mitigation of systemic inequities. That means that we need community engagement and public-private partnerships to address complex public health problems. And I do believe that we're missing a key factor in creating healthier communities. And I hope to expose that through this paper. Thank you so much.